Good evening, everybody. This is Dr. Rick Lehman in St. Louis in your corner with CORA. And tonight we're going to be talking about a very important topic, meniscal tears, somewhat as it relates to football. And meniscal tears may be one of the most common things that sports doctors, orthopedic surgeons, et cetera, see. So this should be a very, very interesting segment. Dr. Yoldas, can you please introduce yourself?
Yes, hi, I'm Erol Yoldas. I'm a orthopedic sports medicine specialist in South Florida. I've had the pleasure of being the team physician for the Miami Dolphins for several years, as well as the Florida Marlins baseball team, and for numerous colleges down here. So I've enjoyed taking care of athletes on the professional and recreational level.
Thank you very much. Joe?
Yes, I'm Joseph Bernreuter.
Buddy?
I'm Joseph Bernreuter. I'm the doctor of physical therapy at the Orthopedic Specialty Institute with Dr. Yoldas. I've been in his circle working with both professional athletes and recreational athletes for close to 10 years now, and we've been working together at the Orthopedic Specialty Institute for about 2 to 3 years now.
Gentlemen, thank you very much. So we're going to start out talking about the anatomy of the meniscus and talk about the blood supply, the portions that are vascular and the portions that are avascular. Dr. Yoldas, if you could explain the anatomy and then tell us why it's important, why it matters if there's blood supply or there isn't blood supply, number one, and how that pertains to tears of the meniscus, number two.
Yeah, absolutely. Sort of jumping to some of your last points first. We heal because of vascularity. We cannot heal things that don't get good blood supply. So if you break your nail, it doesn't bleed, hence it doesn't heal. So getting nutrition, oxygen, all the growth factors to a piece of tissue is essential for it to mend. So when we talk about the meniscus, there are two sort of C-shaped structures, mirror images on each side, go from the front to the back of the knee, and they have an attachment on the outside, what we call the capsule. And along that margin, they have a little bit of blood supply. There's some great articles of staining of the perfusion of it, but basically for a couple millimeters along that border, it has a bleeding potential. A little bit more pronounced when we're younger than when we're older, like most. And so when we look at tears of the meniscus, where it's torn, whether it's within that border where there's vascularity, or in the vast majority of the rest of the meniscus, where there's not vascularity, dictates whether we think it can heal on its own, or requires stitches, or requires other forms of treatment.
That's awesome. Thank you. And along those same lines, explain to us the epidemiology of meniscus tears, medial meniscus versus lateral meniscus, what you see most commonly in your practice, and maybe more importantly, associated injuries with medial and or lateral meniscus tears.
Like most things, it all depends on the condition and the etiology, to use a fancy term, but in general, there are more medial meniscus tears than lateral. That's on the inside part of your knee. However, when we look at certain injury patterns, like when you tear your ACL, a ligament in the knee shifts, particularly on the lateral side, hence acutely, meaning at the time of injury, that lateral meniscus is more susceptible to an injury at the same time of tearing that ligament. So depends when we're looking at this and what other injury patterns are present.
And in an older patient, which maybe that's not your practice, what kind of meniscus tears do you see, medial versus lateral? And are the architecture of the meniscal tears different in a degenerative tear, an older individual, compared to your 23-year-old college football player who might tear his meniscus?
Absolutely. And it's sort of, not to get confusing, but so we talk about what side the meniscus is torn, medial, lateral. Then we talk about the location where it's, we'll say, peripheral by the blood supply or not. But then we talk about the orientation of the tear. Is it longitudinal or up and down? Or is it horizontal across, almost like if you cut open a pita bread? Or is it across its structure, what we'll say radially, like somebody took a knife right across it? And there can even be some pieces of torn tissue which tear and flip into the wrong spot, like we'll call a displaced fragment or a bucket handle tear. in general, if we look at an older individual where the tissue quality is weakening, they often tear it horizontally. Where if we look at a young football player who tore his ACL, it may be more of that radial type of tear pattern or even a flipped piece of meniscus. So orientation of the tear pattern, location of where it is, and age all sort of work together to make a sort of uniform presentation.
That's awesome. And explain to me about the meniscal root. We hear all these people talk about meniscal root tears and things called ramp lesions. Explain to us what the meniscal root is and how that affects the biomechanics of the knee and how that also affects stress transfer as it relates to the anterior root and the posterior root of both the medial and lateral meniscus.
Sure. The meniscus structures I sort of demonstrated with my hands here, C-shaped, and it's secured around the periphery to the joint capsule. But at the beginning and the end, or vice versa, it is anchored down to the bone, basically inside the knee. We call that the root. If for some reason through an injury or trauma or through the course of a surgery, that attachment to the back, or what we call the root, is disrupted, it allows that piece of meniscus tissue to move. So now as we're trying to prevent forces from going up and down, this piece of meniscus tissue can move out of the way if that root is disrupted. So having a good anchoring point keeps that cushion in place, and without that, the cushion is sort of less optimal and then theoretically may increase your risk of degenerative changes over the subsequent time period of months and years.
That's awesome. And I think that's right. I think we're just appreciating those root tears more frequently now and are more aggressive in repairing them. And we'll talk about repairing them in a minute, but explain your physical exam. Athlete comes in, says, hey, I got hurt playing football. Kind of walk us through what happens, how you make the diagnosis, what your physical exam would suggest or could suggest, and any specialty tests that you do to try to determine, is a meniscus torn, is a meniscus not torn?
One thing that I always like to do, and I tell everybody that is working with me, or I'll use the word learning from me, I often love to watch the patient when they don't think you're watching them. So I watch how they walk from the chair to the examining table. I watch how they're getting down the hallway, whether there's a true limp or something exaggerated when they're thinking they're being observed. But watching somebody move naturally gives you a sense of how much they're hurting and where they might be hurting. With that being said, on the examining table, first, obviously, you look at the knee, see if there's any malalignment, etc. But you look for an effusion in the knee. I first do a hyperextension to the knee, meaning straightening it out even beyond the point of normal, seeing if there's any soreness with that. Then I'll take the knee and then I'll bend it or flex it, getting the heel towards their bottom, straight back, and getting that to elicit any pain. Once it's there, I will rotate the ankle back and forth internally and externally in what's called a Flexion-McMurray test to see if it elicits any mechanical symptoms or any pain. I will also then, when the knee is bent 90 degrees, press around the medial and lateral joint line to see if there's what we call joint line tenderness. Lastly, I may have them stand only on that affected leg and try to do a single leg dip. So if we take all those 4 or 5 tests together, Flechion-McMurray, Thessaly, things like that, if most of them are positive, statistically, and I forget the number, it might be 70 to 80% chance that there is a torn meniscus. So even without all our technology of imaging, those just very simple exam findings can really pinpoint whether you're on the mark or not with a torn meniscus.
And do you x-ray every one of these patients, or do you not x-ray these patients?
I'm smiling because we do have to play deference to our insurance friends that pay for these bills. And in a young individual, other than very young, we're worried about growth plate injuries. Often, let's say you don't have to, but in terms of proceeding to an MRI, sometimes it's a precursor to obtain to an x-ray. So do I think it's often necessary for a certain age population? No, but we do that just for secondary effect of getting to the other imaging studies.
And if somebody comes in and you're pretty sure they have a meniscus tear, they have a locked knee, they're having medial joint line tenderness, maybe they're having trouble on getting full extension, do you as a matter of routine MRI them? And maybe the same question is the insurance company dictating for all of us that we have to get an MRI if we want to go ahead and proceed with a surgical resolution?
That actually was very important to us just about 3 or 4 weeks ago. I have a young man who is going to be playing D1 baseball for an ACC school, had a locked meniscus where he truly was locked at about 45 to 60 degrees, could not extend it to get the MRI because he needed to be in more extension, but the insurance company put up a big fight. It took me a while to just get them to acknowledge that this kid's knee was not going to move regardless of intent or pain medicine. And of course, he had a locked bucket handle lateral meniscus. So it takes a lot more effort to do that, but sometimes you have to go through the fight when necessary.
And how accurate is the MRI? I mean, are you more likely to trend towards your physical exam, or if you see an MRI, how do you use that information? And again, how accurate do you think the MRIs are in terms of helping you with the diagnosis of meniscal pathology?
I think it depends on the type of tear in general, but I think if you look at all comers, there probably is about 95% sensitivity and specificity nowadays. However, I never look at the report just alone. I look at the images myself, because if I have a high index of clinical suspicion on exam, I'm going to want to make sure I see that report and image together as well. I think there are also some tear patterns, such as a radial tear, which, as we know, are a thin slice, that if the gantry, the way the images are sliced, happens to cut across it just obliquely, that may not be appreciated. So I think it's important to not just rely on the information given to you, but look at the information directly, the data with that.
That's really excellent. And I think that's exactly right. I think if I have a strong clinical suspicion and the MRI is negative, more times than not, if you arthroscope the knee, your clinical suspicion kind of wins.
Yes.
And I agree with that. So getting into the treatment for this, things have changed. When I came out of my residency or my sports fellowship, we operated on all these meniscal tears. And now there's certainly a little bit of a trend in terms of degenerative tears to not treat them surgically. So give me your thoughts on, again, the 22, 23-year-old D1 baseball player who's got a torn meniscus, maybe not a locked knee or a bucket, but a torn meniscus. And then give me your thoughts on the 55-year-old golfer who comes in with a horizontal cleavage tear, some degeneration, and got an MRI and it shows that he's got a tear. Walk us through how you're going to treat those two different patients.
Yeah, I think taking the first case of the young, we'll call active individual, once again, tear location dictates what we do. If we see a radial tear, etc., I know that's not going to heal and probably best simply addressed with arthroscopically treating that. If there's a small peripheral capsule rent or tear, maybe with some rest that can heal on its own, but I will be more proactive about treating that population surgically. With the 55-year-old degenerative tear or horizontal tear, I think you have a very good chance of pursuing therapy, activity modification, and getting that to settle down enough where they can function well. It might take a little bit longer than what they like, but I think giving them a chance to heal will go a long way, and you can always come back to a surgical procedure for them. Importantly, in that 55, 60-year-old population, what does the rest of the knee look like? Do you have other chondral damage, what we'll call articular cartilage damage, which might make it less optimal to perform surgery on and the outcomes? So you sort of have to look at everything, but yes, I'm more aggressive in the younger population than the degenerative older population.
That's a good answer. So let me be the devil's advocate. You got the 55-year-old guy, the x-rays look actually pretty good, not a lot of arthritis, not a lot of patellofemoral breakdown, telling you that he's having trouble walking the golf carts or getting out of the golf cart, having trouble daily activities, walking on uneven ground. You try maybe a cortisone injection or a PRP injection, whatever your favor, and he doesn't get better. What is the likelihood he's going to get better surgically?
The way I would phrase it to the patient, and it's sort of cliche, is I cannot make it perfect. I cannot make it the knee of a 20-year-old, I like to say. So if we have passed through these certain hurdles and you say, I can try, I can't make it perfect. So whether you become 40% better or 80% better, I don't know. But we have to have that understanding going in that there is a limitation of the outcome. And I think that comes to the cliche of the come to Jesus moment of whether you're both on the same page.
Excellent. So Joe, Dr. Yoldas has his patient. He says, look, Mr. Jones, you're 55 years old. You've got some degenerative arthritis, some joint space narrowing. I'm going to send you for physical therapy. Kind of explain the rehab for that patient, and then conservative care for that patient. And then we'll kind of move on to conservative care for somebody who's got maybe a non-displaced meniscus tear, and they're going to try to play until the end of the season.
Yeah, so we'll start with the 55-year-old more degenerative tear. The first thing, we want to look for is if there's really acute exacerbation of their symptoms. And if there was, a moment where they twisted their knee and things have gotten a lot worse, there's going to be some management there of edema and regaining range of motion. And when it comes to that range of motion, we really always want to focus on extension first, because we always have to kind of play worst case scenario and really focus on the basics. And we need them to be able to walk with an appropriate gait pattern that's not going to affect any other part of their body, and then obviously affect the knee more. So regaining that extension, and along with that, regaining really good quad function, especially of the VMO, to get more stability in the knee would probably be the first things that you really want to achieve there. From there, if there's flexion range of motion loss, you obviously want to regain that. And then you start to really talk to the person about, in the 55-year-old case, about maybe some behavioral changes with the way that they exercise, if they exercise, how they do certain things. We can get into not squatting too deep for certain things so that the meniscus doesn't go under such compressive forces with certain exercises. And then from there, we can really start to get into obviously strengthening the quads, hamstrings, calves. But what we really want to look at in the holistic view for what Dr. Yoldas mentioned as it may take a little longer is we want to really start to look at the hip and the ankle and see if there's any contributing factors there that is causing more stress to the knee, especially for the degenerative changes, because those things are really just going to be kind of hard roadblocks to get past if a patient has really poor hip function, whether it be range of motion or strength, and ankle function, that it might be really hard for them to overcome conservatively if they don't address these things. And also getting into body weight will be really important, that if the patient is overweight, losing weight can be a really big factor in managing those more degenerative tears. As far as a more acute situation, patient has a certain tear, they're younger, they want to finish the season out, it's really going to come to athletic testing after all the previous mentioned factors. Obviously, if they can, function with basic ADLs, that was where you start, but then it's going to start to get into more mimicking the type of stresses that they're undergoing in their sport. So for somebody that's maybe a rower, maybe not so bad, right? But when we get into a football player, tennis player, where there's going to be a lot of rotational and pivoting capacity involved in that sport, along with contact, then, that person's really going to have to operate at a high level. Maybe even a brace might help. But the big key would be mimicking those forces that they can take, and hopefully building them up to that capacity through exercise, and gradually introducing those forces through, maybe it's landing forces if the sport has a lot of jumping, if it's a basketball athlete, with a tennis athlete, a lot of hard stopping and pivoting and changing direction would be really important. And then football would be the really big one, where we're really putting the contact aspect in there. And we really need to see them operate at a high level before we really gave them the vote of confidence to continue on with conservative treatment and avoid surgery, and hope that other structures don't become compromised in the knee.
So explain to me one more thing. I mean, and I think that was excellent. The athlete comes in, he's 55, he's a golfer, he plays pickleball, whatever he plays. And, you're looking at the alignment of his knee. Explain varus or bow-leggedness and valgus and how that figures into your paradigm as to treatment.
Yeah. So we'll start with the most common thing we'll see a lot is a really bad valgus deformity of the knee. And so we're going to say, basically, we're looking at the knees folding in. We see that more often than the knees folding out. When we see that, we know just without even having a medical background, you could guess, you just see the stress across the knee, right? Just push on your shirt and look at the stress lines that it creates, right? So when we see that, that's a really good point, that we know that they're going to be predisposed to a certain amount of extra force to the inside of the knee. And we look at that, that's where we really look at a kind of a joke in the PT world, is we always say the knee is the middle child of the body. Somewhere along the line, more than likely, that hip and ankle function started to really contribute to the extra valgus force in that knee there, whether it be strength of the external rotators, for the femur to be able to rotate it back out, because usually we see a lot of internal rotation happening with those valgus deformities. So there's a lot of education on the patient that we can't always just change that. If it's very mild, sometimes we can make a really big difference there. But if, it's really apparent to the naked eye and you can measure that angle to be, at pretty drastic. I mean, if you have somebody that is going to be over 25 degrees there, you're starting to get into pretty drastic changes at the body and how the hip is going to function, the ankle is going to function there too. There's a little bit of education that's going to go to them that they may not be able to keep certain activities up for quite some time into their life without surgical intervention. For more of a varus deformity, you can look at it again and now see more compressive force to the inside of the knee, because you just, again, to the naked eye, you don't need a medical degree to see that the inside of the knee is now tilting onto itself, creating that bowed out appearance of the knee. So from there, we can assume that there's going to be a lot more compressive force in there. We have that varus kind of deformity on the inside of the knee. And again, it's going to be a lot of education to them that we can't fix these structural problems with just simple exercises. Now we can, however, decrease the amount of force that's going to those painful structures and affecting other things like the LCL and the MCL, depending on the deformity. Now, whether or not that matches that person's quality of life becomes kind of more of a personal conversation with them and what their expectations are. Now, those patients, a lot of times, we're looking at maybe even older than 55, and maybe sometimes, anecdotally, it starts to just turn into more of a total knee replacement once the deformity gets so bad. I'm sure you can look at different research and see certain objective measures indicate more aggressive procedures like total knee replacements based on the measurements taken and how those line up with their MRIs and the degenerative structures in there.
And if somebody does come in, you're treating Dr. Yoldas' patient conservatively. He's, again, moderate demand, golfer, runner, pickleball player, and he's got a degenerative meniscus tear, maybe a little bit of swelling, having some pain. How long do you think, and the first question he's going to ask you is, Joe, when can I go back to playing pickleball? When can I go back to playing golf? Give us your thoughts on return to sport. What are we talking about time-wise? And what does he have to do to make those steps to get back to playing his chosen sport?
So the way I love to start that conversation, and we're going to take your example of, there's a little bit of an acute aspect to maybe not the injury, but just the exacerbation of symptoms. And I'll always tell the patient that until we get that fluid off of that knee, it's going to be really hard to train the capacity of the knee. So I always tell them, let's not talk timeline until we can get that under control a little bit. Now, usually with just a degenerative tear, we would love to see that edema really get out of that knee within 1 to 2 weeks. And then from there, we would look at anywhere probably from a month to 8 weeks of pretty solid training would usually get them back. It can definitely happen faster than that for some people. But what I really try to instill in the patient is the realization that there needs to be a lifestyle change that comes along with it. So it's not as simple of, all right, my knee's not swollen, I'm walking a straight line, let me go back to pickleball. a lot of times these patients are not complementing their athletic desires, their weekend warrior desires, with the type of workouts that they're doing. So I also have to educate them that I'm not only rehabbing your knee, but I'm exposing you to new things that maybe you haven't done in the past and that you need to work on. So that's really why I give a range of 1 to 2 months there for a full return, because there's got to be a little bit of freedom in there for me to teach you new things that you're not familiar with. So there's a learning curve there, rather than just throwing you on the leg press and telling you to do a certain amount of reps. That's really easy to do. I got to teach you how to be able to pivot, maintain good body mechanics, change direction. So 4 to 8 weeks is usually a pretty safe thing to begin your conversation with. But you really want to stress to a patient that it's more than an achievement in overcoming certain obstacles rather than waiting for a knee to get better and for you to return to sport and achieve the things that you want to achieve. You have to try to take maybe your strength or body mechanics to the next level so that you can do these things.
Awesome. And so gentleman comes in, got a BMI of 34, my knee's killing me. Do you ever talk to them about their BMI? Do you ever suggest a weight loss program or something to maybe unlock? You mentioned it before. How important is that in sort of this lifestyle change you're talking about?
It's extremely important. And as a physical therapist, it really becomes very individual to the therapist, right? So for myself, I've really taken the initiative to learn more about nutrition, not just for myself and how I lift weights and the type of body that I want to get, but more for general populations, whether it be my elderly or my young athlete patient. So it's something that I always try to start them on and try to educate them on a little bit. And it goes further than just reducing BMI. It goes into hydration levels, their water intake on a daily basis, their sleep habits. All these things are going to determine their ultimate outcome and their longevity and what they can do. Now, where physical therapists may run into problems is you got to be really careful and really good about your medical history and your background before you start really talking nutrition with people. Because if you just start spouting off really general information, you could get some people into tricky situations where if you're not really good at managing a diabetic patient or anything like that. So also having the we'll say being humble enough to realize that you need to refer out or maybe try to guide them to other community resources that they can use, whether it be a nutritionist, dietitian, to really help them out and then take that team approach. But I do think that every physical therapist should at least expose their patient to the knowledge of how much that factors into their rehab. And if they feel comfortable, they should try to take an active role in that. But if they don't, they need to try to refer or try to get somebody in their circle that they can get to communicate with these patients a little bit to just more so maybe light the fire that, you know, inspires them to get there. If you're not really comfortable taking that on, and that's a whole other job, you know what I mean? To try and really take on somebody's nutritional advice with them, because that's a 24-hour-a-day thing, you know what I mean? They come into the clinic, I work with them for a certain amount of time, I educate them on what I need them to do at home, and from there it's on them. But when you're talking nutrition, that is an ongoing thing, and like I said, it plays much more into their sleep habits, how they manage stress in their life. All those things are going to really play in. So I think that you should always get the process started, and then from where, you know, how serious of a situation it is, you may need other medical professionals to really help you out there.
Thank you.